All right, picture this. You're right in the thick of a busy ER shift. That overhead page echoes a known type 1 diabetic coming in hot.
Yep.
You hustle to the room, and, well, before you even lay eyes on the patient, you catch that smell. It's unmistakable.
That fruity smell.
Yeah, that weird, sweet, fruity smell, almost like, I don't know, a nail salon exploded or something. Then you see the patient, they're breathing deep, fast, almost gasping, maybe 28 times a minute.
Multismal respirations, yeah.
Exactly. They're clutching their abdomen, clearly in pain, and then you glance at the glucometer. It's just screaming, "High GH!"
Off the charts, usually.
Right. So, expert, for many of us, that whole picture immediately flashes one diagnosis, doesn't it? DKA.
Classic DKA presentation, no doubt.
But what's that very first instinct, the one we almost automatically jump to when we see that crazy high sugar? And importantly, why is that the exact instinct we need to fight against in DKA?
You've hit on the critical first trap, absolutely.
Right.
Our immediate, almost reflexive urge is just, nuke the sugar, get that number down with insulin, fast. But in DKA, that alarming high glucose reading, it's basically an imposter. It's a mask. It's a really loud symptom that distracts us from the truly life-threatening crisis happening underneath, which is profound dehydration and just chaotic electrolyte imbalances. It's a mess. If we can correctly identify and, crucially, fix that underlying physiological disaster first, the sugar, it'll actually start to follow along. It often corrects itself to a large degree just with fluids.
Okay.
It's really about treating the cause, not just chasing that most obvious symptom.
So for you amazing ER nurses listening today, our mission with this deep dive is, well, it's absolutely critical. We want to arm you with a precise roadmap, the exact battle-tested order of operations you need to tackle this three-headed monster of DKA effectively and safely. That's key.
Safety first, always.
We're going to make sure you're not just reacting to symptoms, but truly understanding and correcting the core problem right from that moment the patient rolls through your door. So let's unpack this DKA mystery. Let's start with what's actually going on inside the patient's body.
Okay, so what's really fascinating here, and often kind of misunderstood, is that the high blood sugar, it's a major player, but it isn't the primary villain we need to tackle first.
Okay.
Think of insulin as the key, right? It unlocks the cell doors, lets the sugar in so the cells can use it for fuel.
Got it.
In DKA, that key is either totally missing, like in type 1 diabetes, or it just doesn't work right. So you end up with this really profound paradox. The patient's cells are literally starving, desperate for energy.
Even though there's sugar everywhere.
Exactly. Even though they're swimming in this vast sugary ocean, it's kind of like being stranded on a raft at sea and dying of thirst,
Yeah.
Water everywhere, but you can't actually use it.
Wow. Starving cells in a sea of sugar. That's a really powerful, almost desperate image. And, okay, so when the cells are starving, despite all that glucose, the body then has to scramble, right? It needs to find another fuel source.
Precisely. And that's where the real trouble kicks in. In this, desperate, panicked response, the body's internal power plant just switches gears entirely. It starts burning fat for energy because it simply cannot access the sugar.
Okay, fat burning.
But this emergency fuel source, the fat breakdown, it comes with a toxic byproduct, ketones. And ketones basically are acid.
Right, the K in DKA.
That's the one, ketoacidosis. So imagine just a truckload of these highly acidic ketones pouring into the bloodstream. It rapidly turns the blood acidic, leading the patient straight into what we call metabolic acidosis. And this isn't just a mild shift, it's a dramatic systemic acidification. It can start shutting down vital bodily functions pretty quickly.
So we've got cells starving for fuel, the blood turning dangerously acidic, which already sounds like a complete nightmare. But there's that third piece, equally devastating, that I think often gets underestimated, especially when we're just staring at that high glucose number. That's the dehydration, right? How severe are we talking?
Oh, it's absolutely catastrophic. It really is.
Yeah.
Visualize all that excess sugar piled up in the blood. It acts like a super absorbent sponge.
Okay.
It just aggressively pulls water out of everywhere, every cell, every tissue, every little nook and cranny of the body. Meanwhile, your kidneys are in this frantic losing battle trying to get rid of all this sugar.
Trying to pee it out.
Exactly. They go into overdrive, producing massive amounts of urine. But because of the osmotic pull of that sugar, gallons upon gallons of precious body water follow that sugar right out of the patient.
Gallons. Seriously.
We're talking anywhere from a staggering 5 to 10 liters of fluid loss in some severe cases.
10 liters. That's wild to even wrap your head around, especially when you're just looking at a patient who might just seem a little dry, you know?
It's profound. And that's why, hosts, when that DKA patient rolls in, the very first, most important thing you will ever do is start hanging fluids. You are essentially trying to rehydrate a desert urgently.
Okay, 10 liters down. Wow, so now we fundamentally understand the what behind DKA, the starting cells, the acid, the massive dehydration. Let's pivot right into the how. When that DKA patient hits your ER doors, it's go time. Every second, every decision needs urgency, needs precision. What does that critical first 30 minutes of action look like for our ER nurses listening?
Right, that initial phase is all about laying the groundwork, swiftly and effectively. First things first, get the big pipes.
Big pipes.
You absolutely need 2 large bore IVs. We're talking 18 gauge ideally, maybe even bigger if you can manage it.
Okay, 2 18s. Why so critical?
This isn't just for convenience. It's literally for survival. This patient is profoundly volume depleted, remember, a physiological desert, and you're about to start a rapid high volume infusion to basically create an oasis. Good, robust IV access now saves you and the patient immense struggle and precious time later on when you might be managing multiple drips and needing more access points anyway.
Makes sense. Get it done early.
I can't tell you how many times I've seen folks struggle later because they settled for a smaller line early on. Get those big lines up front.
2 18s. Got it. The mantra. And while you're securing that critical access, you're also drawing a rainbow, right? Pulling all the essential intel we need to guide treatment. What are the absolute must-have labs?
Exactly. While you or your colleague is getting that access, get those tubes filled. The CMP, the Comprehensive Metabolic Panel, that's king here.
Well, why the CMP specifically?
We're laser focused on potassium, obviously, which we'll get into. And bicarb is essential for calculating the anion gap. That gap is our key marker for how active that acid factory still is.
Okay, potassium, bicarb, anion gap. What else?
A VBG, a venous blood gas, is usually perfect, gives you a quick pH reading. It's much less invasive than sticking an artery and gives us enough data for initial DKA management.
Good. Avoid the art stick if possible.
Yeah. And critically, get serum ketones, specifically beta-hydroxybutyrate if your lab runs it. That confirms the K in DKA. It ties all the physiological pieces together and gives us that baseline for monitoring how well we're doing.
Got it. CMP, VBG, serum ketones, anything else right at the start?
Oh, absolutely. Get them on the cardiac monitor immediately. Continuous monitoring. Those potassium shifts we're about to dive into, they can trigger lethal arrhythmias like that.
Right. Monitor on.
And a baseline 12-lead EKG is also non-negotiable. You need to know if there are any pre-existing issues or acute changes happening right now.
Okay, so we've got the big IV access going in. We've got our critical labs drawn and heading off. But before those tubes even hit the pneumatic tube system, what's the single most important initial intervention? The one that needs to happen, like, right now?
Fluids first, always. I cannot stress this enough.
Yeah.
Before you even think about insulin, before those initial labs even pop up on the screen, get a liter of normal saline hanging and running wide open.
Why?
Bolus it in.
Wide open.
Wide open. This is not negotiable. This is the single most crucial initial step. You have to start correcting that monumental 5 to 10 liter fluid deficit immediately.
Okay.
I've seen nurses hesitate. They see that sky-high glucose and they want to jump straight to insulin.
Yeah.
But you simply cannot manage DKA effectively without tackling that massive dehydration first.
Yeah.
And let me say it again. Do not start insulin yet.
Yeah.
Fluid resuscitation is absolutely paramount.
No insulin yet. Wow. Even with the glucometer just screaming at us, that feels so incredibly counterintuitive, doesn't it? Pushing against that instinct to just fix the high sugar.
It does.
Yeah.
But it's the right move.
But you're saying fluids are the absolute priority. Okay. And speaking of counterintuitive, this is where it gets really interesting and potentially really scary. Potassium. You hear it called the silent killer in DKA sometimes, right? Why is it so sneaky? Why does that initial lab report often tell us a physiological, a lie?
It truly is the sneakiest player on the field, host. And this is where super careful attention to detail can literally save a life. That initial potassium level you see on the lab report, the K+ sort.
Yeah.
It's often not the full truth. It's more like a physiological illusion. The severe acidosis, all that acid in the blood, actually shoves potassium out of the cells and into the bloodstream.
Okay, so it forces K+ out.
Right. Which can make the serum level, the one you measure in the blood, look normal, or
Yeah.
sometimes even deceptively high. Gives you this false sense of security. But here's the kicker. This patient has been having that massive osmotic diuresis, remember? Peeing like crazy for days because of the
Yeah.
high sugar. And they've been peeing out huge amounts of potassium along with all that water.
So their total body stores are actually low.
Profoundly low. Dangerously empty. Even if that first lab number looks okay, their total body potassium is depleted.
Okay, so the patient is actually in a total body potassium deficit, even if the lab report initially hides it. And then comes the moment of truth, or maybe the fatal plunge.
Yeah.
The very second we do finally introduce insulin, what happens then?
Exactly. This is the critical point. The second you start that insulin drip, those cellular doors, which were essentially locked shut by the lack of insulin, suddenly fly wide open.
Okay.
And all that serum potassium, the stuff that was artificially propped up in the bloodstream by the acidosis, it rushes back inside the cells with alarming speed.
Oh, wow.
So if you haven't diligently addressed the patient's true, profound total body potassium deficit before starting that insulin, their serum potassium level will just plummet precipitously.
And that leads to?
That rapid drop can, and often does, lead straight to fatal cardiac arrhythmias, ventricular fibrillation, asystole. It's incredibly dangerous. That's why potassium management is arguably one of the most critical, high-stakes aspects of DKA care. It's a truly precarious balance beam you're walking.
Okay, this is absolutely where we need that rock-solid roadmap, the potassium rules of the road, let's call them, to navigate this treacherous terrain and avoid that fatal plunge. So let's break this down. Clear, actionable steps for our nurses. What's the protocol if that initial potassium level comes back high?
All right, yeah, consider these rules your DKA Bible. Memorize them. If the initial potassium is HIGH, let's say greater than 5.2 MEQL,
Okay, above 5.2.
it is generally considered safe to initiate the insulin drip. You won't add any extra potassium to the IV fluids yet, but, and this is crucial, you absolutely must recheck that potassium level in about 2 hours, maybe even sooner.
Why recheck so soon if it's high?
Because remember, it will drop once that insulin starts working and driving potassium back into the cells. And as the acidosis starts to correct with fluids, you need to anticipate that drop and be ready to start supplementing quickly when it happens.
Okay, high K means start insulin, no potassium yet, but recheck very soon. Got it. What about the sweet spot? What if the K plus is within the normal range?
Right. And if the potassium is normal, let's define that as between 3.3 and 5.2 MEQL. This is where you can start the insulin drip. But you must even, without exception, give potassium replacement at the exact same time.
At this time.
Currently. The standard approach is usually to add about 20 to 40 millieq of potassium chloride, KCl, to every liter of maintenance IV fluid you're infusing. So insulin drip is running and potassium is going in right alongside it in maintenance fluids. It's about maintaining that delicate balance from the start.
Okay, normal K means start insulin A and D, start potassium replacement simultaneously. Makes sense. And then the absolute red flag scenario. What if that initial K plus comes back dangerously low?
Okay, this is the stop sign. If the potassium is LOW, anything less than 3.3 MEQL, you stop. Full stop. Do not start the insulin.
No insulin at all.
Not a single drop.
Yeah.
This is a true medical emergency that demands your immediate and aggressive attention. The patient needs robust potassium replacement before you even think about insulin. You give the potassium, usually IV, carefully. You recheck the lab. And only after that potassium level is safely back up above 3.3 MEQL should you even consider initiating the insulin drip.
Wow.
Ignoring this rule, starting insulin when the K is low, that can directly lead to cardiac arrest. This is a non-negotiable patient safety rule in DKA. Absolutely critical.
Okay, those potassium rules of the road are gold. Absolutely crucial for our ER nurses. A real game changer for understanding safe DKA management. So let's say we followed the rules. We've flooded the patient with fluids. We've meticulously sorted out the potassium situation. Then, and truly only then, it's time for the main event, the insulin drip. When exactly do we pull the trigger?
Right. The insulin drip only begins after you've delivered that initial fluid bolus, really starting to address that dehydration. And just as crucially, after you've confirmed that the patient's potassium level is safely within those parameters we just hammered home, getting the timing right, the sequence right, it's everything. Fluids, potassium check, then insulin.
Sequence is key. And there's a neat little practical trick with the IV tubing itself, isn't there? Something about priming the tubing that sounds small but is actually pretty important for getting the right dose.
Yes. Prime the tubing. It's absolutely a real thing, and it's vital, especially with insulin drips. Insulin molecules, for whatever biochemical reason, they tend to stick to the plastic of IV tubing.
Huh. Okay.
So before you actually hook that insulin drip up to your patient, you need to run about 50 milliliters or so of the insulin mixture through the entire length of the IV tubing and just discard it into a waste bag or sink.
Why do that?
It basically coats the pipes. It saturates all those sticky binding sites in the plastic. This ensures that when you finally connect the tubing to the patient, they're receiving the full intended dose of insulin from the very first drop, not some diluted amount because half of it got stuck to the tubing walls on the way in.
Ah, clever. Like seasoning a cast iron pan.
Exactly. It's a small detail, maybe seems fiddly, but it makes a real difference in therapeutic efficacy, especially at the start.
That's a fantastic tip, easily overlooked in the chaos of a busy ER. Okay, so tubing primed, potassium checked and safe, fluids running. How do we actually start the insulin drip? What's the standard dose, and what's our ultimate goal for lowering that glucose?
Okay, the standard starting rate for the insulin drip is zero point 0.1 units per kilogram of body weight per hour. So 0 0.1 units beer up.
0.1 per kilo per hour.
And a really key update here. Some of this changed over the years. We no longer give an IV bolus of insulin upfront in DKA. No push. That's considered an outdated practice now. It can cause more harm than good, frankly, by causing those potassium levels to plummet too fast or increasing the risk of cerebral edema.
Okay, no bolus, just the drip at 0.1 units. And what's the goal? How fast do we want that sugar coming down?
The goal is a slow, steady, controlled reduction in blood glucose. We're typically aiming for a drop of around 50 to 75 milli-GDL per hour. That's the sweet spot.
50 to 75 per hour, not faster.
Definitely not faster.
No.
It truly is a marathon, not a sprint here.
Yeah.
Trying to bring the sugar down too rapidly significantly increases the risk of some really nasty complications, especially cerebral edema. That's particularly a concern in kids, but it can happen in adults too. So slow, consistent, gradual reduction is the name of the game.
Which means
Frequent glucose checks are crucial, like every hour initially, sometimes even more often if things are changing quickly. You need that data to titrate the drip up or down carefully to stay within that 50-75 milli-GDL per hour target range.
slow and steady wins the race. Got it. Okay, now, as that blood sugar starts to gradually come down, maybe it hits 300, then 250, we might feel this sense of relief, right? Like, okay, we're winning.
Yeah, it's tempting to feel that way.
But you've been telling us from the very beginning, we're not just fixing the sugar number, we're fundamentally shutting down that dangerous acid factory. So what's our real finish line here? What actually tells us we've truly corrected the core problem of DKA?
That is such a critical point. Our true finish line isn't just getting the blood sugar below 200 or whatever number seems normal. It's when that acid factory is completely shut down. And the best, most direct measure we have for that factory's production and its eventual closure is the anion gap.
The anion gap.
The anion gap. It's not just some random lab value. It's our direct window into how many unmeasured acids, primarily those toxic ketones we talked about, are still floating around in the patient's blood. When the anion gap closes, meaning it returns to a normal level, typically less than 12, that's your definitive signal. That tells you you successfully treated the underlying metabolic acidosis and the body is no longer churning out those harmful ketones. That's a much deeper, more accurate indicator of resolution than just looking at the glucose level alone.
Okay, closing the anion gap is the real goal. Which brings us to another one of those brilliantly counterintuitive but absolutely vital moves in DKA management. Something that can feel genuinely weird the first time you do it. What happens when the patient's blood sugar does come down nicely? Maybe it hits, say, 200 milli-GDL, but that anion gap is still wide open. It's still high.
Yeah, the gap is still like 18 or 20.
Right. We know we still need that insulin running to keep working on the ketones and close that gap. But if we keep the insulin going at the same rate, their sugar is going to crash, right? It'll go way too low.
This is the classic DKA dilemma. And you're hitting on a crucial point that really separates, I think, good DKA management from great DKA management. You're exactly right. We absolutely need to keep that insulin infusion going to allow the body to metabolize those ketones and finally close that anion gap. That's non-negotiable for fixing the acidosis.
But the sugar?
But if their glucose drops too low, while we're doing that, we create a whole new, equally dangerous problem, hypoglycemia.
Yeah.
So the elegant, brilliant solution is this. You switch your primary IV fluids. You change from normal saline or half-normal saline to fluids that contain dextrose, usually D512 normal saline.
So you start giving them sugar.
You literally start feeding the patient sugar through their IV. You give them dextrose, precisely so you can keep giving them the insulin they desperately still need to resolve the acidosis, but without letting their blood sugar crash into the basement.
Wow. It's like refueling a plane in midair. kinda.
That's a perfect analogy. That's exactly what it is. You keep the engine running, the insulin therapy, because it's essential to reach the destination, which is closing the gap. But you add fuel, the dextrose, to prevent a catastrophic crash, hypoglycemia, along the way.
That really clarifies it. It feels so wrong initially, giving sugar to a diabetic patient, especially one who came in sky high.
It does feel weird.
But it's precisely what you have to do to complete the job safely and effectively, to truly resolve the underlying crisis.
Exactly. It ensures you don't prematurely stop the insulin, which is the only thing fixing the life-threatening acidosis, just because the blood sugar number looks better. If you stop the insulin too soon, that acid factor would just crank right back up.
Okay, that makes perfect sense now. And while this insulin drip is running and we're maybe adding dextrose, we're also keeping an eye on other things too, right? Like other electrolytes, phosphate maybe, and eventually thinking about getting them off the IV insulin altogether.
Oh, absolutely. DKA management is definitely comprehensive. Hypophosphatemia, low phosphate, is another known complication that you need to monitor for and potentially replete, especially as insulin drives phosphate back into the cells, along with potassium.
Right.
And you're spot on. The ultimate goal isn't just getting those stable in the ER. It's ensuring a safe transition back to their normal subcutaneous insulin regimen. We typically look for several things before we even think about turning off that IV insulin drip.
Like what?
The anionic gap needs to be closed. Their bicarbonate level should be normalized, indicating the acidosis is resolved. And critically, the patient needs to be awake, alert, and able to tolerate eating and drinking.
Okay.
And even then, you don't just shut off the IV insulin cold turkey. You'll typically overlap the IV insulin infusion with their first dose of subcutaneous long-acting insulin for an hour or two. This prevents them from slipping right back into DKA, which can happen surprisingly quickly if there's a gap in insulin coverage. It's a whole art form in itself, that transition piece, preparing them for discharge, not just stabilizing them acutely.
This has been such a clear, really systematic breakdown of DKA management. You've highlighted all those nuances that truly matter for us nurses working on the front lines in the ER.
Well, ultimately, I think the bottom line for managing DKA effectively is this. You have to forget that initial obsession with just the sugar number. DKA is way more complex. It's that three-headed monster, remember?
Right.
Profound dehydration, severe metabolic acidosis, and those critical, sneaky potassium derangements.
And our job as that incredible ER nurse you mentioned is to identify and tackle those three heads, but in the correct critical order.
That's the key. The order matters immensely.
That order, just to recap it one more time, is first, drown them with fluids. Rapidly, aggressively, get that volume back up.
Priority one.
Then, meticulously respect the potassium. Understand that physiological lie on the initial lab, know those rules of the road, and manage it with absolute precision.
Critically important.
And only then, after those first two crucial steps are well underway and K+ is safe, then you start that slow and steady insulin drip. Not to just chase the sugar, but to finally shut down that acid factory and close that anion gap.
Get that order right. Truly understand the why behind each step, not just the what. And you will consistently pull your DKA patients back from the brink every single time.
Fantastic. Such critical information. And that, expert, brings us to our final provocative thought for you, our listeners. Considering how DKA really masks its true multifaceted danger as this kind of imposter, right? Wearing that high sugar mask, what other seemingly straightforward patient presentations that roll into your ER might actually be hiding a much deeper, more complex physiological crisis underneath? Something that demands this kind of systematic, ordered thinking, looking beyond the obvious symptom. What stands out to you as another potential imposter you've encountered in your practice, something that wasn't quite what it first seemed, and how did you, or how could you, uncover its true nature?